Right, another MLA micro lecture. So I have combined the presentation of fasciculation with motor neuron disease because the two aspects obviously go together. Do remember that fasciculation is already plural. Never say fasciculations to a neurologist. They get very distressed. So just a bit of basics about motor neuron disease. It's known as ALS in the US. ALS is a subtype in the UK. It's the third most common neurodegenerative disease beyond Alzheimer's disease and Parkinson's disease, and we have 5,000 people in the UK living with it at any one time. It's a sinister diagnosis. Most people know what a diagnosis of MND means. There are famous people and celebrities, particularly in the UK, and generally life expectancy is 2 to 3 years after diagnosis, but some people with bulbar speech and swallowing problems at onset die more quickly, within 12 to 18 months. If people have just involvement of one arm, or it's mainly upper or lower motor neuron, they can have a longer life expectancy. A minority can live up to 10 years. Remember as well that in the US, they can also call it Lou Gehrig disease, and I think Lou Gehrig was a baseball player. He was affected in the 30s or 40s. So motor neuron disease can present in a few different ways, so it's important to know about it. Generally, we describe motor neuron disease as mixed upper and lower motor neuron lesions, which are purely motor without a sensory component. So that is the thing to always come back to. If you're thinking to yourself, does this person have motor neuron disease? When you examine them, look for upper motor neuron features. So do they have spasticity? Do they have brisk reflexes? Do they have upgoing toes, positive Babinski? And do they also have lower motor neuron features? Do they have wasting? Do they have fasciculation of the muscle, so it's a twitching of the muscle, without any sensory loss? That's what you should be looking at. You can get people with sort of a often asymmetric weakness, so people are often a little put off if somebody tends to have more weakness on one side than the other, but in reality there does tend to be some asymmetry. The first presentation, so weak either symmetrically or asymmetrically with brisk reflexes and upgoing toes with wasting and fasciculation, that tends to be the most common presentation. It can begin in one arm or one leg and pretty much involve that exclusively for a while, and that can be lower motor neurons, so they can have a sort of floppy, weak arm or leg, and we call that a flail arm or a flail leg. Those people tend to do a little better. There can be hand wasting, so you can see all the bones kind of become very prominent as there's guttering, as all the muscles kind of waste away in between, and people can struggle with jars or holding a pen, something like that, or a foot drop where people can't pull up the toe, they can't dorsiflex the toe, and they can catch the toe, and that can lead to falls. Bulbar onset, more common in older women where speech and swallowing are affected. They have slurred speech and choking. That tends to have a worse prognosis in my experience. Remember that eye movements should be normal, and there isn't a problem with weakness of sphincter function. So people are continent. They should only really be incontinent, but they physically can't reach the toilet in time. They're aware they need to go, they try to get to the bathroom. So when you examine these patients, you'd expect to see fasciculation of the muscle, so twitching of the muscle. Patients don't usually feel that in the context of motor neuron disease. They will see it. Fasciculation that people are extremely aware of in a state of high anxiety with normal examination can be something called benign fasciculation syndrome, which is more common in healthcare workers who are well aware of motor neuron disease. We would expect to see this over multiple sites, so I tend to look for the tricep, the forearm, the hands, over the scapulae, the deltoids, the quadriceps, all of these places. I wouldn't expect to see fasciculation in somebody who's healthy. In young people who exercise, you can get fasciculation of the calves. So if you only have fasciculation in the calves, nothing else, and not much in terms of examination findings, that is much less likely to be MND, or it's less, pathognomic. General asymmetric weakness can progress from one limb to all limbs over time. Remember that weakness of speech and swallowing can be due to either upper motor neuron involvement of the tongue, so a stiff, slow tongue, which we call pseudobulbar, with a kind of very tight kind of sound to the talking, or a sort of lower motor neuron presentation with a sort of weak, loose, fasciculating, wasted tongue. And people have a slightly different, more slurred speech as a result of that. There should be no sensory findings. Unless somebody has a long-standing nerve issue or sciatica, which is unrelated, I would not expect someone with MND generally to have any sensory findings or numbness. Brisk reflexes is what we would anticipate. So I have a video here which hopefully will work. No, computer, don't restart. So I don't know how good the resolution is here, but you can see fasciculation of the bicep. The patient here in this video, which is available online, can't feel it but can see it. And here I have another video again, this is in the public domain, of fasciculation of the tongue and wasting, and this is very, very obvious. Now, we do tend to tell people when we're examining patients for MND, don't have the patient stick out their tongue, because you can then get little muscle contractions as they do that. We ask them to leave the tongue relaxed in the mouth. It's really hard to do. You sort of ask people to do that. But this is so florid that even sticking the tongue out, you see the fasciculation. So a little bit of fasciculations, which it doesn't matter, it should be fasciculation versus fibrillations. So remember, the fasciculation, involuntary contraction or twitching of muscle fibers, but from one motor unit. And that can be felt by the patient. Sometimes it can be seen by you. It's not exclusively a motor neuron disease. So you can get fasciculation in other muscle disorders. If somebody's had extensive systemic weight loss, you can see some fasciculation if the muscle is atrophied. If somebody has, a nerve injury and wasting of the muscle, you can see fasciculation then. So it's something you can see with the naked eye. Fibrillation is in a single muscle fiber, and that is a neurophysiology finding. So it's something that you need to be wired up, and it's seen electronically on nerve conduction studies and EMG. It's usually caused by denervation, so you can see fibrillation in multiple disorders. But if you see fibrillation, denervation, and there is a context in keeping with motor neuron disease, that is highly suggested. You can see it in things like inflammatory muscle disorders as well. But remember, you do not see fibrillation except on EMG. You see fasciculation. So in terms of history of people with MND, people will talk about muscle wasting and cramping. In the north of England, people talk about withering or weight loss, and they haven't sort of lost abdominal fat. They've got thinning of the arms and legs as their muscles waste. The weakness can include foot drop, so dropping of the foot so they can't dorsiflex and trip. Speech and swallowing problems, speech becoming more indistinct, drooling because they don't have the sort of sufficient swallow to clear their saliva. They can get early morning headaches if there's an element of type 2 respiratory failure. So when they lie down and sleep, their CO2 creeps up. They wake up in the morning, they've got low oxygen levels, they've got high levels of CO2, and they have a headache. And there can be behavioural change, and that's from frontal lobe dysfunction. So people with MND can develop a frontal dementia syndrome. So there may be a lack of insight and impulsive behaviour. We do tend to see this if speech and swallowing is involved. So important differentials. So if there is cervical cord compression, you can get sensory findings. So if people have weakness of the arms and legs, if their findings are pretty much exclusively upper motor neurons, so brisk reflexes, upgoing toes, but you can't really find much in the way of muscle wasting, you can't see fasciculation. If there is nothing above the neck, so nothing cognitive, nothing bulbar, speech and swallowing, then and there is numbness, think about scanning the neck. You can't explain away anything above the neck, so speech and swallowing or cognitive problems, by a tight neck, by cervical cord compression. So myasthenia gravis, so sometimes we think about this if people have got speech and swallowing problems, but the pattern will be different. So people will improve after rest, they'll be better at the beginning of a meal, they will tire as they go through a meal and the swallow will become weaker, they'll stop eating for a bit and then the swallow will become stronger again, they'll call that diurnal variation. And we will see fatigability. So if people have weakness of the arms and legs, they start off strong, you get them to do more movements, and then they become fatigable. It's not what you'd expect to see in MND. And benign fasciculation syndrome, so that's just fasciculation alone, that can be picked up on EMG, but there'll be no other sinister features, no denervation. People will have a largely normal examination otherwise, and it's commonly seen in people with sort of high stress or anxiety, particularly in the context of healthcare workers who may see and work with MND a lot. You can see benign fasciculations with exhaustion, high caffeine and poor nutrition, which is pretty much every medical healthcare worker on call or on nights. So you will see healthcare workers presenting to you concerned that they have MND, and that's a possibility. So with investigations, important to do basic blood tests. Hyperthyroidism can rarely mimic MND, though in practice I've seen it only once. If somebody's systemically unwell, lost a lot of weight, and they have sort of other features like their liver's gone off or the kidneys have gone off, maybe look for malignancy. Imaging might be important if, for example, you suspect cervical cord compression, and nerve conduction study and EMG can be helpful to support the diagnosis. So if you suspect motor neuron disease, it's important to get a neurological opinion quickly. It's important to at least give patients an idea of why they're going to see a doctor. So I'm always very careful to tell my trainees, if you see somebody and they've been referred to you by a GP, and they look at the referral letter, the patient's in front of them, they say, so your GP is suspicious that you have motor neuron disease, and the patient has no idea and are devastated. That's not the right way to communicate something like this. So when you see a patient for any condition, always be sure to ask, do you know why you're here? And then if they don't know, say, well, your GP is a bit worried about your weakness or some wasting in your hand. Let me ask you some questions, let me examine you and go from there. So be sensitive, particularly with things like this, with cancer, with motor neuron disease. These things are highly traumatic for patients, whether they end up having them or not. So communicate well, it's important. And if you are breaking the diagnosis of motor neuron disease, make sure you feel supported enough to do it, make sure you're qualified to do it, and give people the time, the space, and the sensitivity and compassion that they deserve. Make sure their family are with them, if possible. Thank you.